Hi, this is Dr. Crider at Nura Regenexx Edina, and today we'll be doing a running webinar focusing on how to prevent and treat running injuries. My specialty is in physical medicine and rehabilitation, with a specialty in regenerative medicine and interventional orthopedics, and I'm a runner. So this has been a personal and professional interest of mine for a long time, and hopefully there will be something useful here for runners of all levels. So today's outline, we'll start with common running injuries and how those can occur, the mechanics of running and how that can reduce the incidence of running injuries in some ways. Tips to optimize form, I'll try to go through that quickly because I know you're all runners, you all know how to run, but hopefully there'll be something useful here for everyone. How to prevent running injuries through rehabilitation and prehabilitation, and then the role of regenerative medicine in treating many of these overuse injuries without surgery or steroids or excessive downtime. And then a case study of a runner's knee that responded really well to what I do. So my background, I went to University of Minnesota Medical School. I'm a physiatrist. Now I'm practicing regenerative medicine at Nura Precision Pain Management. And it doesn't matter, but I did run track and cross country with some decent times. So it's good to know that you're hearing it from someone who's done it. Common running injuries. So kind of starting in the lower extremities, IT band syndrome, very common on the outside of the hip and also down to the outside of the knee. So that IT band is actually an extension of the muscle of the hip that can be overused if you don't have strength in some of the other muscles of the hip. So that can cause pain at either and is difficult to treat once you have it, but is easier to prevent if you can get there before it starts. Patellofemoral pain syndrome is a pain behind the kneecap. Again, often due to muscle imbalances and overuse. Overuse of patterns that are modifiable. Runner's knee, same idea. This is now right below the patellar tendon, or is the patellar tendon, which is right below the kneecap. And that's an overuse tendinitis or tendinosis because it's not usually inflammatory. It's usually more of a breakdown, overuse kind of injury, usually from overusing the quadriceps. So that is also modifiable. Achilles tendinosis, same idea. Tendons attach muscles to bone, and that's a common area of breakdown in runners. So the Achilles tendon can also respond to various treatments that we do. Shin splints, this is usually pain along the inside of the shin bone, usually as you're increasing your miles rapidly, kind of a precursor to like a stress fracture. And then plantar fasciitis, common in runners and in general population, can actually be related to a pinched nerve in the back as well as kind of tight calves because the calf muscle actually becomes the plantar fascia, and then overuse. And so there are exercises and treatments for that as well. So I thought we'd start by looking at some of the mechanics of running in an example of one of the elite runners in the world. So this is Kipchoge doing a 2-hour marathon right off the world record. This is equivalent to doing, I think, a 4:36 mile times 26. And so it's a good example that it's not necessarily the distance that causes injury, it's the form breakdown that happens as you fatigue running those distances. So if we can try to emulate this sort of form, I think we'll all have much fewer injuries. So focusing on that hip dot first, you see he's not bouncing up and down a lot because he's really absorbing the shocks with his hips and his knees. He drives with the knee, and then the knee is loose when it's behind him so that his ankle can really kick up all the way up towards his butt, and his shin is even going above parallel to the floor. So he's really getting good hip extension and then hip flexion. And leaping off that back foot. And you can't do that unless you're really getting good hip movements to activate the glutes. So now as it zooms in on his feet, you'll see that he has a good midfoot strike, meaning that his foot is landing below him, and his foot's already starting to move backwards as it hits the ground. So there's no braking forces. Every step is pushing him forwards. The foot's even a little bit plantar flexed as it hits the ground, which further allows the midfoot strike. And he's got a little bit of knee bend as he hits the ground, and so he's not landing with a straight leg that'll give him that braking force. So going head to toe on some running form tips that will influence kind of the injuries that all of those injuries at the top are ultimately related to an unideal form that is leading to overuse injuries. So one of the main things is having a slight forward lean. We'll come back to this over and over again, but in the first picture he has a very upright form where he's kind of leaning back at the low back and his head is looking up. So you want to keep the whole body straight leaning forward. So the eyes are going straight forward. Sometimes when people hear they want to lean forward, they're doing it at the hip and leaning like that, which would obviously not be ideal because you'd still have your body in front of you. Go look straight ahead, not up, not down. Keep the shoulders down, back, and loose. So as you get tired, these shoulders tend to ride up. And then rather than swinging at the shoulders, you tend to rotate the entire torso and the arms swing back and forth across the body, which is a wasted motion, lots of trunk rotation, and that also reduces the ability to drive the hips and knees because these are really counterbalanced by the arm swing. So if the shoulders come up, you have less arm swing, and then you can't get the knees up. So that's something that you can really focus on as you get tired, is keeping the hips down and swinging at the arms. And ultimately, the pace of your arms will drive the legs. So as you get tired and the legs get tired, concentrate on your arms and the legs will follow. So as the arms swing forward and backward, the hand is going to go from the side to the elbow at the side, and they shouldn't really go any more across the body or forward, backward than that. Elbows would be at about 90 degrees. Hands loose at the sides. Again, by allowing the arms to swing, then you won't have to have the trunk rotation, and that trunk rotation introduces areas of breakdown everywhere else in the chain. So focusing on having your belly button pointing forward will help you be aware of that trunk rotation. Pulling the belly button in engages the core in this position, versus when you're leaning back, you're not really engaging the core at all. And so that's why we tend to fall into this position, is because our core fatigues. And so focusing on this will keep you in this. And also imagining yourself being tall will also keep you in that sort of form. Going back to the low back now, you do not want to be arched. So when I say you want to lean forward, that is not leaning forward at the pelvis or the hips. You want the low back to be in that straight position. Focus on pulling the pelvis back and slightly anterior, meaning that you're not, I think I've got another picture of that later. One really important thing to focus on is the waistline dip. So as you're standing on one leg, your gluteus medius muscle out here actually is supporting this leg, which is otherwise unsupported. So this half of the body would want to dip down like this, unless you've got a muscle over here to pull down on this, which pulls up on the other side. So it's this muscle pulling down, which lifts the unsupported side. When that muscle is weak, this whole side dips down, and then you see all the other things that happen. This shoulder drops, and her whole center of gravity has to shift over to the right so that she's balanced over the one foot, because otherwise, ideally, this muscle will make up for the fact that this side is unsupported. If you don't have that, then you have to have a lot of these lateral shifts of range of motion, which puts a lot of stress over the IT band. So that's why we're saying IT band is an overuse injury related to muscle weakness, is that you end up kind of relying on this strap out here to bear the weight rather than using the muscle. So ultimately, your speed and power comes from your gluteal muscles, which allow you to leap off of that back foot onto the other one. And so focusing on really getting good hip extension will allow you to activate the glutes, and we'll talk more about that. Everything should be kind of straight up and down, hips, thighs above, knees above shin. You want the knees to be loose so the ankle swings back freely. We showed that in the video. You want to be coming all the way back to here. If you're really tight and keeping your knees straight more, then you're not getting that extension with the leg behind you, and you can't really involve your glutes. Slight bend at the knee when the foot hits the ground. That way, when you land, you've got a spring which can, and even at a little bit of bend at the hip too, absorbs some of that strength, some of that force as you land, and then is able to store it and re-release it the next step without having to recreate that force with each step. Otherwise, if you're landing with a straight knee, then all of that force is going through your bones, and a good chunk of that force is actually pushing backwards on you rather than here where everything is moving forward. And this is when your knee is loose as you drive, then everything below the knee is just a passive pendulum coming forward. You don't have to think about driving forward like with your hip flexors. You drive forward with your knee, and then everything else happens passively. and angling forward at foot strike would allow that heel strike more, which is going to send all those forces up, and it's going to be an overstride, where that distance there is all wasted energy due to the braking force of landing ahead of you. Having that toe pointed up kind of is a sign that you're probably heel striking and overstriding, versus landing with your foot more flat or even a little bit down means that you're landing with your foot underneath you. And if you find that your foot whips out to the side as you bring this back leg through, it's probably because you're not getting enough hip flexion to clear the ground. So when your legs stay relatively straight with each step, then you can't really clear this foot unless you also bring it around. So that foot whipping out to the side is a sign of not really using your hips enough. So one of our goals for preventing injury is maybe transitioning you from more of this heel strike, overstride, into more of a midfoot strike, where you've got that forward lean and you're landing onto your center of gravity underneath you. So some of those tips I talked about is not having the toe pointed up, not landing ahead of you, and landing such that your foot is already moving backwards as it lands, with your weight kind of here rather than really driving with the heel. So there are certainly shoes that promote that. So you can go to a specialized running store and talk to them about that. And then obviously physical therapists can also work with you on transitioning to more of this midfoot strike. There's tools like 100 ups, where you're kind of going up on your toes like a jump rope, will kind of help train you to use your calves as a spring rather than landing on the heel. So we've all heard of this idea of ideal cadence being 180 steps per minute. This will get you more towards that sprinting or middle distance form where you're lean forward and landing on your midfoot. But the 180 is not an exact number. It varies based on how tall you are. But aiming towards a quicker turnover is probably helpful for most runners. So to do that, try to work in some speed work or intervals, high intensity intervals, fartleks. Those are all really good tools to, even if you can't do it for a 30-minute run, if you can do it a couple minutes at a time and gradually extend that, you'll be able to spend more and more time at that more efficient pace. Try to think about landing softly or quietly with light feet. So if you hear yourself clomp, clomp, clomping, that's a lot of forces that are going through the pavement, through your bones. So landing with that midfoot strike, you'll actually absorb a lot of that force in your calf before your heel even hits the ground. And this will be a much quieter landing. And so that's a good way to sense feedback of how much forces you're really putting through versus through your bones versus how much forces you're able to store and release with the next step. If you're minimizing your contact time with the ground or imagining that the ground is hot and you have to get right back off it, that will also help lead you towards this 180 steps per minute and lead you to use your calves and your posterior chain more as a spring rather than as like a peg leg. And we talked about that. So one of the main things that we'll talk about in this webinar is about how to activate, strengthen, and be aware of your posterior chain, which is glutes and hamstrings. Those are going to be your main drivers in running, rather than relying on your quadriceps. So both of those muscle groups work to keep the knee straight so it doesn't collapse underneath you. The quads go through the front of your knee and then through your kneecap and then through your patellar tendon. And that's, if you're relying excessively on quad dominant running, you're going to end up with a lot of kneecap and patellar tendon pain, versus the glutes and hamstrings actually do the exact same job of keeping your knee straight, but they're much stronger and more effective. But a lot of the common running patterns actually inhibit those muscles from being used. So we'll talk about that. We talked about the gluteus medius muscle on the lateral hip. So those are on the back of the hip for the glute max and hamstring. The glute medius is on the lateral hip, and that'll keep the hip from dipping, which will also ultimately stabilize the knee. So a lot of knee pain is actually due to hip weakness. And then work on stretching those hip flexors. I'll explain why hip flexors tend to get tight in runners and how that can limit the hip extension, which is ultimate extension, meaning leg coming out behind you, which is ultimately how you push off. And you can't do that if your hip flexors are all tight. So running uphill tends to strengthen the glutes and hurt the knees less. So try to build more hills into your workout routines. And running downhill puts a lot of stress to the knee. So that's part of why Boston Marathon is so difficult, is it's downhill almost the whole way. It just exhausts your quads. And then Heartbreak Hill, you suddenly have to go uphill 20 miles in. So if you're increasing your mileage too quickly, that is a common cause of especially shin splints, but other running injuries as well. If you're having pain as you ramp up your miles, that's when you would really want to try to follow this 10% rule, meaning don't increase your mileage more than 10% a week. So 30 miles the first week, 33 miles the second week, 37. It's very slow and frustrating. I would say you only really need to follow that if you're having pain. And it's hard to really tell what your pain coming and going and what mileage you're doing unless you're really keeping track of it in a diary. So I recommend keeping track of your mileage and what workouts you've done and how it feels, and then you'll be able to look back and tell if something's been becoming a nagging injury or not healing or becoming abnormal, and dial down accordingly. So one of the main things for preventing running injuries is listening to your body and changing your regimen if you're starting to get abnormal pain. So, soreness after is normal. Soreness at the beginning that goes away is normal. If you're getting sharp pains or pain that is not getting better a mile in, think about just turning around and doing cross training. You are not wedded to whatever marathon training plan you found. It's more important to avoid injury. That is the ultimate, how to succeed in a marathon is just how to do as many miles without getting injured. And so that relies on listening to your body and cross training. So biking is very good at activating that posterior chain, especially if you're using a high resistance and high cadence. So standing on the pedals with a lot of resistance is going to be almost like a stairmaster and is very good at activating all of the muscles of running. Aqua jogging is very boring and frustrating and doesn't do quite as much at posterior chain, but it's good for aerobics and cadence training and hip flexors. So that's good to add in as well. Circuit training, just going from one body part to another quickly without much rest, will become an aerobic exercise and is great for cardio and many of these gluteal muscles that we were talking about. And if you're going to use a treadmill, try to use at least 3 degrees of incline, because otherwise, the treadmill is moving underneath you, so you never really have to push off at all. You're just having to bounce up and down and let it move under you, which means that you're never really developing that gluteal leap where you're pushing off that back leg to propel yourself forward. You can really just rely on hip flexors and calf kind of to bounce up and down. So do try to get some real life running in outdoors or on a track. But if you're going to use a treadmill, force yourself to push forward and not just up and down. So here we'll explain a little more about that gluteal. It'll make more sense. When this side is unsupported, unless this muscle pulls down on this side to pull this side up, then this whole side drops. And as that side drops, you can imagine what's happening in the stance knee now is that, and in the low back and the shoulder. So you see how it plays out in this picture. As that comes down, everything else gets wonky as well. Everything has to shift that way so that she's supported. And that leads to a lot of side-to-side motion. If it's hard to tell if you're doing this, and so looking at how you do squats and lunges will be a good test for you. So a normal squat would mean you're sitting backwards and your knees are able to stay above your toes. If you've got weakness on the outside of your hip, then as you do a squat, this knee is going to dive in like that and put a lot of force on the outside of the knee. So if your squats look like this, then talk to your therapist or trainer and really focus on keeping your knees above your toes. A lunge demonstrates the similar issue where as he does his forward lunge, the knee wants to go like that. Versus you would really want it to be straight above your toe. You don't want your knee to go ahead of your toe. That's too far of a lunge. So you really only want to lunge to, about a 90 degree before you go to the next, or a squat before you go to the next, because this puts a lot of pressure on the kneecap as well. And this is a box jump, same kind of weakness. This also predisposes to ACL injuries in cutting sports, non-contact injuries. So just another reason to strengthen those gluteal muscles to normalize the movements at the knee. So this is a common pattern in everybody, but certainly plays out in runners as well, where rather than activate the abdominal muscles, we tend to tip forward a little bit and rely on low back and hip flexor to keep us upright. that also disinhibits the gluteal muscles. And so you can see how that plays out here, where the whole pelvis tips forward, the hip flexors actually contribute to that. So these get so tight that it pulls the whole thing forward, which actually stretches out the hamstrings. And when they're in this stretched out position, they're not able to effectively contract either. So it really disinhibits this whole posterior chain when you're tipped forward like that. And obviously it's cranking on your low back. And if you're running in this kind of a position, then you're going to have to really have an excessive low back upright in order to still be looking forwards. So again, focusing on pulling your pelvis back a little bit will keep you a little more upright, although obviously you want to have that slight forward lean. And will put your hamstrings in a position that they're able to contract effectively. So if you find that you have tight hip flexors and a sore low back, this is called the lower crossed syndrome. So this is another way of looking at quad dominant versus posterior chain dominant. It's going to be one of the major effectors of knee pain and running, and also related to how you're doing squats and lunges. So if you're doing this sort of a squat where the knee is in front of the toes and the angle of the shin is very forwards, that's putting all of the force through the quad, through the kneecap, through the patellar tendon. And it's going to cause a lot of knee pain to go into this position and a lot of knee pain to get out of it. Versus if you're doing the squat properly, it's going to be like you're sitting way out behind you, and that allows more of a 90-degree at the knee, less shin forward angle. The knees stay behind the toes, and it's activating. Now all the forces are going through the glutes rather than through the quads. So this is what you want your squats to be looking like in order to really protect your knee as a runner. So now looking at, that's all been focused on how the muscles influence how your joints move and influence risk of injury. But a good point to make is that your nerves control your muscles. And so even if you've been training your muscles, you may not be getting a good muscle response due to problems with your nerves. So this is a video by Dr. Centeno, who's one of the founders of Regenexx out in Colorado. This is a video of normal running motion where everything is straight. And then the next video is actually of him running, where you'll see, first he's got a lot of side-to-side motion, so a lot going on rotationally. But also we're going to focus on his right knee, where he's got a pinched nerve in his right low back that influences how his knee moves. So as it lands out here, it wants to dive inward towards this green line is kind of where the center line would be. And so he lands with it out where it should be, and then it dives in towards this line due to that muscle weakness. So it shoots in like that. It steps out to the side and then pops in towards the line. And that's happening with every step, despite the fact that he knows that he's got this kind of weakness. He's tried training that muscle. The muscle's not responding because he's got a pinched nerve in his back. And here it shows what happens to that meniscus every time that knee dives in. He's got lateral knee pain due to meniscus degeneration, an unstable meniscus due to muscular nerve problems in his low back causing the muscles to not activate properly. That can affect similarly, you know, the foot muscles that contract to hold the arch together. If those aren't activating properly from the same kind of nerve in the low back, different nerve in the low back, you can also get plantar fasciitis. So a lot of these tendon and ligament issues are actually due to nerve issues higher upstream. Other things that protect joints and stabilize are the ligaments. So ligaments connect bone to bone. So here you've got MCL and LCL. And if those are loose, it's like a loose tire that wears out more quickly. You also have ligaments that hold the meniscus down onto the bone called coronary ligaments. And if you've had meniscus surgeries especially, or major meniscus injuries, then that meniscus becomes unstable and wants to move around as well. And all of those instability and excess motion will cause accelerated wear and tear and cause a lot of pain. So this video on the left is the patient's right side, which is mildly lax. So as he stretches this ligament over the top, you see these two bones move apart a little bit, and this meniscus here squishes in and out a little bit. So again, The meniscus is kind of moving in and out between those bones a little bit as this ligament allows slightly too much movement between these two bones. This side is more lax, and you'll see how much more the meniscus sucks in and out. So this bone on the left is moving a lot more due to the ligament over the top being loose, and this meniscus just sucks in and out with every step, and that'll lead to accelerated wear and tear. This is another video now by Dr. Centeno showing how the ACL stabilizes the knee. So the primary role of the ACL is keeping the tibia from moving forward on the femur, but it also prevents rotation of the tibia on the femur. And so this is an example not of someone who had a full ACL tear that would be treated with surgery, but just a loose ACL, an ACL that was not as tight at preventing some of those abnormal motions. And you'll see how that can influence the meniscus as well. So on the left, the tibia on the right is being rotated on the femur, and that meniscus is the little triangle between them, which is staying pretty stable. Same patient now on the opposite side, he rotates the tibia with a loose ACL, and you see how much extra movement is occurring on that meniscus. So everything we can do to tighten ligaments will further stabilize all the other structures in the knee and prevent wear and tear. Next is tendons. So muscles attached to bone via tendon. It's like a rope, and it should be like a rope that's cross-linked. That's what makes it strong. It's made up of all these individual fibers. You can get these areas where the fibers are actually loose and they're not cross-linked well together, and that's called tendinopathy. So it's not inflammatory, it's just degenerative. And these fibers are painful. So when the muscle contracts and it wants to pull through that area, you're gonna have a lot of pain and ultimately weakness because it disinhibits the muscle. And we can see that on ultrasound, you can see it on histology. So this is a normal Achilles tendon with thickness that's uniform and fibers that you can track that go along the whole thing. Versus this lower picture is like a tendinopathy or tendinitis, where you've got normal tendon down below here, and then this area where it's all very thickened and you lose those normal fibers when it's just like really spotty now. We see that on ultrasound. Here's a light microscope where you can see the bottom half is normal fibers that are going lengthwise versus up here, they're all very disorganized and painful. Another area that protects the joint and can become painful is some of these supporting structures around a joint. So in the knee, you've got your meniscus, you also have a labrum in the hip and the shoulder. And these are little spacers that sit between the cartilages and distribute the force outward. So it protects the cartilage. Unfortunately, what can happen with time is develop little tears in here. And that's normal. If you scan 50% of middle-aged people on the street, they're going to have meniscus tears that are asymptomatic. So it's not always painful. When it becomes painful is when the joint becomes inflamed or when that meniscus becomes unstable. And one of the things that can make a meniscus unstable is actually surgery to remove those tears. And so the surgery is typically to just cut out this piece of it that's torn, which ultimately makes this section that remains less stable, so it moves around more when you're doing those forces. It's more likely to re-tear, and ultimately they end up having to take the whole thing out, at which point you then start wearing away cartilage instead. So everything you can do to keep your meniscus intact, even if you have a tear, most of those are responding to physical therapy or regenerative medicine without having to disrupt the integrity of that meniscus. And unfortunately, all four of these things that protect your joints often don't get better with kind of the standard treatments of therapy, rest, non-steroidal anti-inflammatories like Advil and ibuprofen, or steroid shots. Those aren't things that you can train, they're intrinsic, but that's where we come in with regenerative medicine. So we can actually use your body's own healing cells to repair orthopedic injuries. We take the cells responsible for that process out of your body, either from your blood in the case of platelet-rich plasma, where the platelets contain growth factors that stimulate repair, or we can also do stem cell treatments where we remove your own bone marrow, concentrate out your own stem cells, and then re-inject them the same day into these areas of degeneration, because a lot of these areas get poor blood flow and don't tend to heal well on their own. So if these are becoming chronic injuries that you're not able to repair, we can actually restart that repair process using your own cells. So often that's either stem cells or platelet-rich plasma. They both work in a similar way by stabilizing ligaments, calming down the inflammation, by actually stimulating a brief inflammatory period followed by a healing response. It can repair the tendons, strengthen the cartilage, and improve the nerve input to muscles when we treat nerves with platelet lysate. So this is a good example of a patient of ours, 30-year-old woman with 12 years of patellar tendonitis. So she had played soccer year-round since high school on that concrete with carpet over at the old school, turf, and had been having anterior knee pain since high school from that crunchy feeling and sound even when she would do squats or lunges. And every once in a while it would flare up and even walking would be difficult. So we did an ultrasound beforehand and it showed the thickening of this tendon, kind of like that picture we saw before where it goes from there and it just bulges up. You can track the fibers along here until you get to this area where now you've got these black gaps where you lose the edge of those fibers. And then ultimately as they come in and attach to the bone, you just have a big tear there. And when tendon is no longer attached to bone, you start to resorb the bone. They feed each other. And so the bone is even starting to resorb due to that tear. So we did one PRP treatment to her knees, and she was actually back quicker than we would have liked. We would have recommended 4 to 6 weeks off running. She was back in 3 to 4, but was without pain. So she had no trouble running or on this downhill ski trip. Complete resolution of the crunchy sound and feeling. She also used to have burning pain in the front of the knee, which completely resolved. Now she's doing aerobic exercise every day without pain a year later. So she has not even required a second treatment, which is also atypical. Often these are 2 to 3 treatments, but she did great after just 1. And here's her post MRI 1 year later, where now the tendon is flat all the way through, normal thickness. She now has fibers that are crossing all the way across with, it's still a little dark here, but that's much better than the previous one and, relatively normal for her tendon. And she's importantly regrown that area of tendon and the bone where it attaches. So very, very successful case, but not uncommon. So we're really able to treat a lot of these overuse injuries by repairing the degeneration that's occurred and improving the muscle activation and the ligamentous stability without having to remove any tissues or put in any kind of toxic cover-ups. And all of these treatments have a lot less downtime and restrictions afterwards than a lot of the surgical orthopedic options. So feel free, we're new evaluations are covered by insurance. So there's no downside to just coming in and speaking with me if you have any of these chronic injuries. We also have regenerative specialists who can answer just kind of general questions about regenerative medicine and what we do here. Or you can certainly just research yourself on some of these things. We have a very good website at regenexedina.com, which has resources like before and after MRIs. It's got our outcome registry, so we've been following all the outcomes of our procedures since 2006, and it's searchable by body part and by outcome, thousands of patients, and also then links to a lot of the research studies that Regenexx has done and outside studies about this. So it's not new, it's not experimental, it's not covered, but it is very effective at reversing a lot of these overuse injuries. So come on in for an evaluation, and I'm happy to help you however I can. Thanks a lot for listening. Have a good day.